topic is acute laryngitis. So, now the definition and presentation. It is the inflammatory process in the mucosa of the vocal cords and larynx. So, it has abrupt onset which lasts less than 3 weeks. It is self-limited. Its typical symptoms are the hoarse voice, sensation of tickling, rawness in the throat, dry cough, and mild fever. Its etiopathogenesis, it is mainly caused by viral infections or traumatic like excessive shouting or inhalation of toxic fumes, direct injury or bacterial infections. There is edema and hyperemia of the damaged laryngeal structures. And its etiopathogenesis leads to loss of function of this phonation and external breathing. So here in the chart you can see that the effect of 1 millimeter of edema of the cross sectional area of the subglottis larynx in the neonate child and adult. And in the neonate the subglottic region is the narrowest part of the airway, while in the adult the vocal cords are between the vocal area is the narrowest path. So, if there is a 1 millimeter edema in the neonate, it will lead to reduction in the airway area of 75%, while in the adult it is 27%. Now, how will you diagnose? The diagnosis of laryngitis is based on the symptoms, and direct laryngoscopy if symptoms are more than 3 weeks. So, as you here in the picture, you can see the in acute viral laryngitis there is edema and inflammation of all the laryngeal structures, while in the right side you can see the normal larynx. Now, what is the differential diagnosis of importance? So, it has to be differentiated from reflux laryngopharyngitis or infectious or allergic chronic laryngitis or spasmodic dysphonia. Now, what is the therapy? Patient has to do voice rest, steam inhalations, smoking cessation, cough suppression like dextromethorphan, and corticosteroids should not be prescribed on regular basis. Now, when acute laryngitis must be taken seriously, in pediatric patients, it is a medical emergency. Pediatric epiglottitis, it is a medical emergency. Its etiologies are H. influenza, B type and non-B type. Sometimes Streptococcus pneumoniae, pyogens and Staph aureus also. It is seen in the 2 to 4 years of age, which has rapid onset like 2 to 6 hours, which are having fever, sore throat and stridor complaints. The diagnosis is based on the clinical findings, and indirect laryngoscopy is not recommended. The lateral soft tissue xray shows thumb sign. So here in the picture you can see this posterior one are the vertebrae and anteriorly, upper one is the jawline, and the down you can see epiglottis, and now near down the trachea will start. This is the thyroid cartilage, and down the cricoid and the tracheal rings. So here in the picture you can see edema and arrow. Anteriorly is the hyoid bone, posteriorly is the epiglottis, and edema you can see the thumb sign. Now, how will you do airway maintenance? By general anesthesia or oro or nasotracheal intubation or direct laryngoscopy. If you do, you can see the cherry red swollen epiglottis, false vocal cords, arytenoid folds. Subglottic region may be normal or minimally involved. And we have to do cultural sensitivity. Now, empirical antibiotic therapy, we can give ampicillin or sulbactam or second or third generation cephalosporins. Now, one case report is there, like a 65-year-old woman presents with history of sore throat, mild fever with chills, generalized malaise, with previous history of obesity, type 2 diabetes mellitus, hyperlipidemia, proteinuria, and osteoarthritis. So she was prescribed Tamiflu, that is oseltamivir, and returned on the following day with complaint of progressive dysphagia, dyspnea, severe sore throat, drooling of the saliva, and increased neck swelling. It was sent to the emergency department. And on physical examination, temperature was 35.6 with heart rate, respiratory rate, BP, and watch for the blood oxygen saturation. Everything was normal. Cervical lymphadenopathy was present with tenderness on the palpation was seen. And the chest X-ray revealed clear lungs, normal pleura, and a normal sized heart. But X-ray neck showed prominence of the epiglottis and upper tracheal narrowing, confirming the epiglottitis. Now lateral neck X-ray showing this epiglottitis. Therapy, we will give intravenous dexamethasone 10 mg straight, then in the tapering dose, and injectables ceftriaxone 1 gram or vancomycin 1 gram. These are antibiotics. 3 days after admission, the patient showed an improvement in the breathing and swallowing and was able to speak. Patient was discharged home and oral cephalexin was prescribed. Culture sample revealed H. influenza type 1. Okay. This is all about laryngitis. Thank you.